We will discuss about wet age-related macular degeneration, choroidal neovascular membrane, how to diagnose, what are the types and how many injections to be given and how does the patient present. So coming broad topic of choroidal neovascular membrane, wet AMD. So I want to let's make it a little interactive. So I want to ask Dr. Daneshwari. So what in your clinical practice, daily clinical practice, which patients have you encountered? I mean, what are the CNVMs have you encountered?
AMD is the most common cause of irreversible vision decrease, and there is wet AMD and dry AMD. Dry AMD is more common than wet AMD, sir. So then types of AMD, there is AERDS classification also, sir, and the CNVN classification. AERDS classification, there is 4 stages, that is no AMD, early AMD, intermediate and advanced AMD. So in no AMD is very few drusen's, then early AMD is less than 65 microns, few drusen's, with few intermediate like around 125 micron. Then intermediate is many 125 micron drusen's, and then advanced is atrophy or there is CNV. So again CNVM is classified into types like type 1 is occult, that is sub-RP. Type 2 is classic CNVM, that is subretinal. Then type 3 is polypoidal RAP, retinal angiomatous.
Right. That entity we will get to know as we discuss further. So coming to the first, as Dr. Daneshwari said, dry AMD. So now earlier the classification was based on fundus fluorescein angiography. On FFA it was based on the type 1, type 2. Type had a late leakage of undefined fluorescence. So that was for occult CNVM. That's why it is called as occult CNVM. Okay, classic CNVM had fluorescence with the late stages, late hyperfluorescence, like the increase in intensity and the size. So that was classic CNVM. Okay, so now what is the main diagnostic criteria? We are moving on to the less invasive method, OCT and OCT angiography. So wherever OCT angiography is still evolving, and because of many factors, and now we mostly discuss regarding we diagnose the CNVM based on the OCT. Now suppose it is we have a patient of, what will the patient present with, and regarding I want to ask regarding the biomarkers in the dry AMD. Dr. Shreya, what will the patient present with?
If in case it's a wet AMD, there'd be a sudden diminution over a period of 10 to 15 days or a month. But in the case of dry AMD, it is going to be extremely gradual. When we talk about the biomarkers in the case of CNVM, we have to look at different levels. We have to look for
the dry AMD, the biomarkers.
For the dry AMD, the biomarkers will be drusen's.
Okay.
And the size of them. Along with that,
suppose it has progressed to, very nicely said, drusen's, and suppose it has progressed to geographic. So what are the two things we are looking at? We are looking at the two things to allow us to predict for the progression to the wet AMD.
Whether or not there is any vestin coming.
Oh, then
fluid
that is a wet AMD.
And the fluid.
No, that is a wet AMD, but it's not still a wet AMD, but the probability of progressing to wet AMD is much higher on those biomarkers. There are two biomarkers which are defined in the literature as complete retinal and outer retinal atrophy, and that is called CRORA, and incomplete retinal and outer retinal atrophy.
If in case the photoreceptors are damaged, and that area is more than 125 micrometer.
No. So in case the ELM and the EZ, there is a atrophy, and the RP atrophy, which is, so what happens when there is an atrophy, the signal will travel through the choroid. So there will be a hypertransmission into the choroid. So hypertransmission into the choroid less than 250 micrometer is incomplete retinal and outer retinal atrophy, and more than 250 micron will be the complete retinal and outer retinal atrophy. So these two diagnostic criteria will have a more these two biomarkers will have a more probability of progressing to wet CNVM. And the thing to read is that if sometimes the below the drusen there is a hyperreflective material oozing out from the drusen, is called as the drusen ooze. Okay, so somewhere if we see a material drusen ooze, then it has a higher probability of progressing to wet ARMD. And the patient, if they are progressing to wet ARMD, what I generally like is the practice also what we generally give for the home monitoring of the patient. Amsler grid we give to check for any metamorphopsia, and AREDS formula antioxidants are given. You can give for 3 months, then 1 month gap, then again 3 months, or you can give for one OD dosage alternative for lifelong. Okay, and so these are the types of CNV. So based on the OCT, so we have a spectral domain optical coherence tomography here, OCT. So based on the OCT, so there are basic three types of CNVM. So coming to Dr. Himanshi, so what are the types of CNVM? So for type 1 CNVM, so what will be the type in type 1 CNVM, what will be the OCT findings in the type 1?
Sir, in type 1 CNVM, there will be drusen in the sub-RPE location.
Okay, the drusens are there. Drusens are the dry AMD.
Yes,
so
sir.
What will happen in the type 1 CNV is a type of wet age-related macular degeneration.
Yes, sir.
So wet age-related macular degeneration means the choroidal neovascular membrane has formed and is leaking out some fluid. So
Yes,
that's
sir.
why it is wet. So where will be the location of the fluid predominantly will be in type
Sir,
1 CNV?
in sub-RPE space.
Sub-RPE
Yes, sir.
space. Okay, type 1 CNVM. So suppose a patient comes with a diminution of vision and metamorphopsia, and
Yes,
we
sir.
do an OCT, we are suspecting some subretinal fluid on clinical examination, and we do an OCT and
Yes.
find this type of OCT picture.
Yes,
Focus
sir.
on this type of OCT picture. So what will you counsel the patient? What will you how will you we have made the diagnosis based on the OCT as type 1 CNVM. He's a pseudophakic patient.
Injection monthly, initially
Okay.
for 3 months, and then every 6 injections, sir.
Right. And suppose I am the patient asks, suppose I am the patient कि ma'am how many injections will I get, कितने injections लगेंगे and कितने time तक मेरे को injection लगाना पड़ेगा?
Sir, 3 injections.
More number of injections than classic.
हाँ, right. So it requires
It requires occult CNVM requires more number of injections than classic CNVMs. Slow responding.
So मैम मैं तो पेशेंट हूँ, मेरे को क्लासिक सी पता, मेरे को कितने लगेंगे इसमें? डॉक्टर हिमांशु, मेरे को कितने लगेंगे इसमें इंजेक्शन?
20 to 40.
No,
20 to 40. After the 3 months, we can go do a treat and extend regimen. So there are 2 regimens described in the literature: treat and extend and pro-renata regimen, that is the PRN regimen. So Dr. Anuj, can you throw some light on what is treat and extend and what is PRN regimen?
With any fluid, then we'll go for another injection.
Suppose I am this patient, so I have first 3 months 3 injections I have you have given to me. My fluid has resolved. So first possibility, the fluid has resolved. Then I come back after on the 4th month and you do an OCT. My vision is stable. There is no fluid. There is no activity. So what will you? How will you counsel me? So like what will you do? Should you inject? Should you observe or should you?
We will observe.
Observe. And मेरे को कब आना है वापस?
Then after 8 weeks.
हाँ?
8 weeks.
8 weeks? No.
2 weeks.
2 weeks.
1 month and 2 weeks.
So 1 month and 2 weeks. So add 6 weeks. So after the 6 weeks, so that is the. So what does the treat and extend regimen says? After 3 months, if the fluid is not there, so in the given injection, extend the follow up to 6 weeks. So if I come back after 6 weeks, there is no activity, then they will treat again. Then they extend the follow up to 8 weeks. But what happens in this thing, it's not possible because of the financial considerations here. So what we do is we monitor first three loading doses. Then what I do is, if there is no activity, I call the patient after 1 month. If there is no activity, then I increase the follow-up to 6 weeks. Still there is no activity, I increase the follow-up to 8 weeks. I do not treat, I do increase the follow-up to, that is what I practice, till 8 weeks.
And if in case there is no activity for 6 weeks, otherwise we treat and then we again wait for 8 weeks.
No, if the activity comes back, suppose after 6 weeks we called, if the activity comes back, so डॉक्टर साहब मेरे को तो दोबारा कम दिखने लग गया, दोबारा मेरे को ट्यूबलाइट टेढ़ी दिख रही है, एक आंख बंद करूँ तो I will inject and decrease the follow-up by 2 weeks again. Okay, so it was 6 weeks follow-up, then it became 4-week follow-up. So this is the protocol we follow.
In case there is no fluid after 3 months at all, even at 6 weeks and even at 8 weeks, at that point of time we are not going to treat at all. I'm not talking about economic consideration, I'm talking about generally.
In my practice, I won't treat. I will increase the follow-up to 10 weeks.
And otherwise the regimen is that even if there is nothing, do we give an injection at 6 weeks?
We give an injection and increase the follow-up
to 8 weeks. But we are not practicing it because of the economic consideration.
And what is the PRN regimen? When there is fluid, inject without extent. So, suppose.
Then we don't inject in the follow-ups. Any follow-up.
So we follow a mixture of the two, treat and extend and PRN. So suppose Dr. Himanshi, you should go for this thing, ranibizumab injection. So suppose Dr. Himanshi injected intravitreal ranibizumab. After 1 month, my fluid is stable. So again, fluid decreased. So my vision also improved. So again, she gave me 1 more ranibizumab. Then my vision was stable. So how will you go about the third injection? So I said, ma'am, ki injection, first injection से तो फर्क पड़ा. I will ask Dr. Sudhanshu sir कि first injection से तो फर्क पड़ा, पर second injection से नहीं पड़ा. So what will be your choice of third injections?
At least in 3 first loading dose, it should be same. If it is not responding, even after 3 months, we can switch for higher one like Epidemiology.
So, it is type 2 CNVM, Dr. Sudhanshu.
Classical CNVM, in which we see subretinal fluid along with intraretinal fluid.
Okay, right. So, type 2 CNVM is a classic CNVM. Some examples of
RP and neovascularization reach beyond the RP also.
Yeah. So, some examples of type 2 CNVM, Dr. Daneshwari. Yes, vision with a bleed at the macula, subretinally at the macula. So, what was that type? Young female, 34-year-old. We gave an injection day before yesterday. Yesterday only, Dr. Anuj gave.
CNVM bleed was there.
Yeah. So, what was the type?
Type 2.
Type 2, classic CNVM. So, and second types, suppose that if there is a high myope, can high myopes are prone for this thing?
CNVM.
So, what are the type? Type 2, classic. Myopic CNVM. Suppose there is a post-inflammatory, post-toxoplasma, post-choroiditis, post-inflammatory CNVMs are? Type 2, okay. So post-choroiditis, sometimes there is post-toxoplasma CNVM, sometimes there are mostly of type 2. So they require, as you said, lesser number of injection as compared to type 1 CNVMs, okay.